Our next speaker is Dr. Samia Latif. She's consultant in infectious diseases in East Midlands. She's going to share her experience of experimental learning through reflective practice. Thank you.
Hello, good afternoon, and assalamu alaikum, everyone. It's a pleasure being here amongst such esteemed colleagues and this august house. My bread and butter is dealing with outbreaks of infectious diseases and the day-to-day management of infectious diseases, as well as non-infectious incidents. But I'm going to share with you some of the learning that comes out of the incidents that we've dealt with. And I know a lot has been said about patient safety and how we can make our healthcare system, how we can deliver a more quality-assured healthcare system. So hopefully these will give you some tools to do that. Right, does anyone know who this is, or what this is, or who sculpted it? Yes, exactly, brilliant. So it's called La Pensée, and it means the thinker. And it's meant to epitomize the highest form of contemplation, and that wherein lies the art of reflecting. So what is reflection? Reflection is when you look back on a clinical activity or a situation that you've dealt with, and you evaluate it, and you reflect or think on the outcomes, and think back as to how things developed, how you would do things differently, or what you've taken out of that learning. So it's both an art and a science, and it focuses not only on what you see on the surface, but what you need to look for and what you need to dig deeper for. And I think one key mistake a lot of us make, well, I used to when I came from Pakistan, when I would reflect, I would only focus on what had gone wrong or the negative things. We don't celebrate our achievements or what went well. And I've over time learned that we need to balance the both. So it's achievements as well as improvements. So experiential learning is when you take an experience and you put it into action. So it becomes a learning opportunity. And I'm going to, due to the shortage of time, I won't go into the detail, but I will pick up one tool and one model, and I've applied it to incidents that I've dealt with at work. So the tools are using case reviews, debriefs, or guided reflection. And the models, a few of you will be familiar with, the fishbone model, GAS, which is gathering information, analyzing it, and then summarizing it. SHARP, OSAD, and plan, study, do, act. Right. So the fishbone model, or the Ishikawa model, is something that we used when we had a patient who died of sepsis. Did many of you watch the Panorama program on sepsis recently? Right. So one of those patients was actually in our catchment population. And the Ishikawa model uses a root cause analysis approach. It's a structured approach to investigate an incident that has happened. In this case, this was mortality due to bacteremia, sepsis that could have been avoided. And I think the key element of a fishbone model is that you involve the whole organization, and you talk to all those who are involved, and you try to get to the bottom of what the cause was. So there's the mortality, and then you've got different domains that you can look on. That's supposed to be the spine of the fish in the middle. Apologies, you can't see it very clearly. So things like the patient factor. This patient had come from a nursing home setting. So already there are implications there that they're vulnerable, they've got the age, so other social factors. Task factors. When the fishbone analysis was done, it turned out that the audit compliance for hand hygiene was less than 55%, which is less than optimal. Communication factors. We've spoken a lot about communication and how important that is with our patients. I think another key aspect is communication between colleagues. When a patient starts their journey in the hospital system and they go from one department to another department or to a ward, sometimes there are lapses in communication. This patient, the A&E consultants had failed to inform the ward about the device, the intravenous device that the patient had. Equipment and resources, working condition factors. We've all heard how overworked we are, how under-resourced we are, understaffed we are. Those things all have an effect on the healthcare delivery. And then organizational and strategic factors. If your trust puts patient safety right on top of their priorities, I think it does trickle down to staff members as to how important a culture of patient safety is. So this we used to get to the bottom of the death of that patient, and it was very helpful because a lot of changes have been implemented. So that was the tool we used. And this is a debrief, which is a model that we used following a national measles outbreak that I led on. So we had 2 students at a school in the East Midlands who developed measles. Measles isn't seen very commonly in the UK. It's not endemic in the UK. We then found links to 2 further students in 2 other schools in 2 other geographical areas outside of the East Midlands. And it turned out that there was a shared common international travel history between all 4 of them. All happened to be unimmunized. So this is the Wakefield generation, the parents who refused to immunize their parents due to Wakefield study on MMR and autism. And we're seeing the effects now because these children are now teenagers and they weren't immunized at the time. So we investigated the outbreak, we took all the actions that we needed, and we resolved the outbreak. And we had a constructive debrief at the end of it. One parent was, well, actually, all the parents were members of parliament. And a Freedom of Information Act, a Freedom of Information request was forwarded to us. So we had to disclose all the information we held on one of the students. And it was very good that we had very good documentation at every step, so we were able to provide that. And I think the constructive debrief looked at how we dealt with that as well. And we had about 20 internal and external individuals from different organizations as well as Public Health England. So some things that went well, Public Health England, we advised and the school, and we gave them an immunization strategy, and the school felt that that was very good because quite a few parents had now consented to vaccination. However, one of the recommendations was due to the high volume of international students, they have now made a policy that they will not admit international students to the school until they have a full vaccination history. So this is some of the learning that we got out of that debrief. Another one was to review Gillick competency and Fraser guidelines about getting information from teenagers. How much could we ask them directly, or how much did we need to go to their parents for? Case-based discussions. I assume most of you here are supervisors, educational or academic supervisors. So when we do a case-based discussion, we're helping our trainees and our registrars to explore their professional judgments and to train them to reflect on the case that they've dealt with and to assess how they applied their knowledge within a certain ethical framework. So feedback, I think, is one of the most important things in an educator and educatee setting. You need to set time aside for it. It needs to be high quality. It needs to be timely and regular. And we know that our appraisals and revalidations, we will discuss cases and we'll have case-based discussions and we look at reflections. And it's not only a GMC requirement, but an NMC requirement, and other organizations will also ask for that. And there are various models that you can use, but reflection and feedback are cyclical, both feed into each other, and the end result should be an action plan for your trainee or your registrar so that they can enhance their learning and learn from the experiences. So I think the most important take-home message from this is to be honest, to focus on the outcomes and the things that went well as the things that didn't go so well. And you could do it face-to-face or you can do it virtually, but debrief with good judgment and be a facilitator, not a dictator or a critic. Right, and that's the end of my presentation.